So, Bismillah ar-Rahman ar-Rahim. In continuation of our previous lectures of poisons, last time we have learned about detail about the list of poisons. So today we learn about antidotes, the use of antidotes. So today we learn about use of. So first, antidote. So you can see in your screen over there, antidote is defined as a substance which counteract the deleterious effects of poison without itself being harmful to the body. Means the harmful action. 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 आप अपना माइक बंद कर दें, माइक बंद कर दें. Yes. So again, repeat that one. Antidote is defined as the substance which counteracts the deleterious effect of the poison without itself being harmful to the body. So when these antidotes are used, when where emetics and gastric lavage is contraindicated. In condition when emesis and gastric lavage is contraindicated, then antidotes are applied. Another one is poisoning by route other than oral required, then these are applied. The poison that escape gastric lavage or vomiting, then you can apply antidotes. In case of already absorbed poison, then the antidotes are applied. Now you can see the type of antidotes are. Number A is physical antidotes, B chemical antidotes, C pharmacological and physiological antidotes, D chelating agents, E universal antidotes, and F is household antidote. The first is physical or mechanical antidotes. So these are defined as antidotes which physically binders the absorption of poison. The first one is demulcent. Now these substances form an oily layer on the gastric mucous membrane so that absorption in the stomach does not occur. Examples of demulcents are oil, butter, ghee, milk of magnesia, white of egg, starch solution, and aluminum hydroxide gel. Demulcents are contraindicated in phenol, phosphorus, organophosphorus, and kerosene poisoning, as these are soluble in oils. Therefore, these are contraindicated. Second is bulky foods. These substances engulf the poison and make it non-available for causing effect and its absorption. So examples are banana, flour suspension, boiled rice and mashed potatoes. Third is activated charcoal. Now what do it? It absorbs the poison and thereby making it non-available for absorption. It is given 1 to 2 gram per kg in 8 ml diluents per grams. Now chemical antidotes. Sorry. These substances chemically react with poison and thereby alter its chemical nature. Certain substances which react with poison and make it inert are as, first is weak alkalis. There can be calcium oxide and magnesium oxide for acid poisoning. Weak acids, acetic acid, vinegar, lime juice for alkali poisoning. Calcium carbonate for oxalic acid poisoning. Sodium and magnesium sulfate for lead poisoning. Copper sulfate for phosphorus poisoning. sodium thiosulfate for iodine and cyanide poisoning, potassium ferrocyanide for copper poisoning, hydrated ferric oxide for arsenic poisoning, sodium formaldehyde, sulfoxylate in mercury poisoning, tannins, forms a complex with metal, alkalides, and glucosides. Now, potassium permanganate 1 in 1000 and weak solution of iodine 10 to 15 drops per 100 ml oxidize the poisons. Now, pharmacological or physiological antidotes. These are the substances which have pharmacological opposite action as compared to poison. Its effect on physiology is exact opposite as that of poison. Now, certain substances which have opposite pharmacology action are atropine for pilocarpine poisoning, atropine for organophosphorus poisoning, naloxone for opium and morphine poisoning, chloroform for strychnine poisoning, physiostigmine for datura poisoning, ethyl alcohol for methanol poisoning, and N-acetylcysteine for paracetamol poisoning. Immunotherapy, digoxin, antibodies, and SNAC antivenom are also used. Fourth is chelating agents. Now, these are substances which are used in metal poisoning. They form a non-ionized complex with metal ion so that it's not available for absorption and thereby cannot produce deleterious effects on the body. Now, example of chelating agents are BAL, British anti-leviside, EDTA, cupramine, DFM, that is desferoxamine. Now, British anti-leviside is basically chemical. It is a dimer-caprol. So we ask BL, what is BL? It is a dimer-caprol or 2,3 dimercaptopropanol. 2,3 dimercaptopropanol. So what it do? It is effective in arsenic poison. 2SH group of BAL binds with metal. So BAL is liquid and is given with 10% solution in RIAZ oil or peanut oil with benzyl benzoate, 3 milligram per kg body weight. It is given in deep intramuscularly in gluteal region. It is given 4 hourly in first 2 days, 6 hourly on third day, and 12 hourly till the 10th day. It cannot be given IV for danger of causing embolism due to RIAZ oil. DMSA, succinimers, it is 2,3 dimercaptosuccinic acid, and DMPS, unithol dimercaptopropane sulfonic acid, are the derivatives of dimercaprol, can be used orally 30 milligram per kilogram. BAL uses contraindicated in liver damage, hypertension, and tachycardia. Second is EDTA. It is effective against lead, mercury, and copper poisoning. Specifically used against lead poisoning, as EDTA deplete serum calcium. Calcium nitrate is better option. Therefore, you can use calcium nitrate. It is given either orally 1 gram BD for 5 days. If given IV, 5 ml of 50% solution BD for 5 days. EDTA use is contraindicated in renal damage. Is in contraindicated. Cuprimine, penicillamine, diethylcysteine. Sorry. So it is degradation product of penicillin. It is effective in copper, lead, and mercury poisoning, specifically used in copper poisoning, also useful in Wilson disease, hepato, lenticular degenerations, and cystinuria. It is given orally, 30 milligram per kg in divided doses for 5 to 10 days. Its prolonged use may cause thrombocytopenia, agranulocytosis, skin rashes, and nephrotic syndrome. Fourth one is desfuroxamine, DFM. It is effective in iron poisoning. It is given as orally 8 to 12 gram per day, intramuscular intravenous 2 to 3 gram per day. DFM is also useful in hemochromatosis and thalassemia. Hemochromatosis is where the person has to absorption of iron take place. They can absorb more iron. That's why it's a hemochromatosis. And in thalassemia, it is useful, that is DFM. Now come for the universal antidotes. This antidote is called universal because it can be used in all cases of poisoning, especially when nature of poison is unknown. So universal antidote given 15 to 30 gram orally. It can be repeated 12 to 24 hourly also. The composition of universal antidote is charcoal, 50% 2 parts, obtained from burnt bread or toast, results in the absorption of poison. Magnesium oxide, 25%, 1 part, obtained from milk of magnesia, which results in neutralization of poison. Tannins, 25%, 1 part, obtained from strong tea, which result in precipitate metal alkalides, glucosides, and neutralization of alkali. So now you can say that 50% charcoal, 25% magnesium oxide, and 25% tannins will make a universal antidote. Sorry, the household antidotes. These are substances which are available usually in house and can be used in case of poisoning. First one is milk orally is effective in almost all ingested poisons. Charcoal from burnt bread and toast, banana, potato, and emulsant are physically antidotes. Common salt and mustard powder as emetic agent is starch solution for iodine poisoning. The milk of magnesia for acid poisoning. Vinegar, lemon juice, orange juice for alkali poisonings. Now, elimination of adsorbed poisons, how it is done? It is done by what? Purgation, catharsis, using 30 grams sodium or magnesium sulfate or 50 ml sorbitol. Forced diuresis using furosemide or mannitol infusion. Increased sweating, diaphoresis, hot pack applied or injection, pilocarpine, 5 milligram subcutaneous can be given. Stimulating metabolism in liver using vitamin B complex, peritoneal and hemodialysis, whole bowel irrigation, administration of non-absorbable polyethylene glycol to cause liquid stool to thus wash gut rapidly. Symptomatic treatment, fourth one is that you can give morphine, pethidine, For foot width, for pain, IV fluids for shock, blood for oligemic shock, glucose for hypoglycemia, artificial oxygenation, cardiac stimulants, noradrenaline drip for peripheral circulatory failure, atropine for abdominal pain, luminol or diazepam for convulsion or restlessness, sodium or potassium for electrolyte imbalance, anesthesia for convulsions, adrenaline, antihistamine for anaphylactic reaction can be given. 5 is general care of patient. What you have to do? Warmth, good nursing care, prophylactic antibiotic can be given, physiotherapy for rehabilitation, psychotherapy in attempted suicidal cases can be added. Now how to treat the barbiturate poisoning. For acute barbiturate poisoning, results from ingestion of an overdose, either by accidental or by suicidal attempt. It is symptomatically characterized by depression of CNS, particularly respiratory and peripheral circulatory collapse. Patients show weak and rapid pulse, cold and clumsy skin, slow, rapid and shallow breathing. People may be constricted initially and respond to light, but later on develop paralytic dilations. Fatal complications are atelectasis, bronchoconstriction, and acute renal shutdowns. Now, management of barbiturate poisoning, how to do that one? In general, sedative hypnotic drugs are non-selective in their effect. At low doses, a reduction in restlessness and emotional tension occurs. At increasingly higher doses, sedation is followed by increasing level of anesthesia and eventually death. The severity of barbituric poisoning is assessed by clinical examinations prior to treatment and correlate with plasma level of barbiturates, presence of reflexes, response to painful stimuli, maintenance of blood pressure, and respiration without external assistance indicates fair prognosis. The plasma barbiturates concentration of for short-acting barbiturates, it may be 35 milligram per liter, and for long-acting barbiturate, 90 milligram per liter indicate unfavorable prognosis. Now, what we have to do? Gastric lavage. Gastric lavage may be performed if the patient present obtunded without 1 hour of ingestion or rapidly deteriorates while in the emergency department. Vomiting can be induced by syrup of ipecac or concentrated salt solution. For prevention of absorption of poison, activated charcoal 20 gram with egg albumin can be given in patients through Ryle's tube and repeated 4 hourly. Then add endotracheal intubations. It is performed when spontaneous respiration is inadequate and also to remove secretion in patients who show depressed cough and pharyngeal reflex. This reduces lung complication by providing adequate ventilation. Now, forced diuresis. This is performed to increase urine excretion of barbiturates. Forced diuresis is potentially dangerous procedure and should be considered to a patient who have take phenobarbital in such dose that patient not survive only by supportive therapy. Diuretics like mannitol and furosemide have been employed for forced diuresis. Mannitol, an osmotic diuretic given IV initially in a dose of 120 ml of 25% solution. Subsequently, a sustained infusion of 5% mannitol, alternatively with saline or 5% dextrose, is administered at the rate of 500 ml per hour for next 3 hours. An average urine volume of 10 to 12 liters in 24 hours is considered as satisfactory diuresis. Furosemide is more powerful diuretics, is used in a dose of 20 milligram along with 500 milliliter of 1.2% sodium bicarbonate and 1 liter of 5% dextrose. Then you have to use alkalinization. It is mild systematic alkalosis, reduces plasma concentration of non-ionized and diffusible form of barbiturates. This leads to withdrawal of barbiturates from brain and CSF. In addition, alkalinization prevents reabsorption of barbiturates and enhances its elimination. This process significantly increases excretion of long-acting barbiturates and not for short-acting barbiturates. Sodium bicarbonate, 3.5 gram per 50 ml, may be added to every liter of fluid attended for IV. The urinary pH should be checked hourly and maintained in between 7.5 to 8.5. Another substance employed as THAM is trihydroxymethyl ammonomethane. THAM, trihydroxymethyl ammonomethane, is administered IV as 1/3 molar solution in 2% sodium chloride. Then they go for dialysis also. Now, peritoneal dialysis or hemodialysis is used to remove barbiturates from body. Both are more effective in removing long-acting barbiturates. Peritoneal dialysis is not more effective than forced diuresis, but hemodialysis is 40 times more effective than forced diuresis in promoting elimination of barbiturates. Now, hemodialysis is especially indicated in following cases: shock and progressive lethal dose level, ingestion of lethal dose in patients with whom peritoneal dialysis is not effective or contraindicated. Now, that was for barbiturates. Now we learn about alcohol poisonings. So for alcohol poison, alcohol is a neurotoxic herbal inhabitants poison. Alcohol is generic term for ethanol, which is particular type of alcohol produced by the fermentation of many foodstuffs, most commonly barley, hops, and grapes. Other types of alcohol commonly available such as methanol, common in glass cleaners, isopropyl alcohol, rubbing alcohol, ethylene glycol, automobile antifreeze solution are highly poisonous when swallowed, even in small quantities. Ethanol is greatly consumed as alcoholic beverage like wine, port, sherry, vodka, etc. Absolute alcohol is 99%. Ethanol, rectified spirit is 95% alcohol, and the natural alcohol is 95% ethanol and 5% methanol. Now, ethyl alcohol and monoamine oxidase inhibitors. Ethanol exerts its action through several mechanisms. For instance, it binds directly to the gamma butyric acid receptor in CNS and causes sedative effects similar to those of benzodiazepine. Sorry. Ethanol is also an N-methyl diasparate glutamate antagonist in the CNS. Ethanol also has direct effects on cardiac muscles, thyroid tissue, and hepatic tissues. Ethanol is rapidly absorbed and peak serum concentration typically occurs 30 to 60 minutes after ingestion. Its absorption into the body starts in the oral mucosa and continues in the stomach and intestine. So acute poison of alcohol, there are 4 stages which characterized by specific symptoms depends upon alcohol concentration. Stage 1 is stage of excitement. In this, blood alcohol level is 50 to 100 milligram per deciliters, characterized by hesitation, self-criticism, and restraint loss, feeling of well-being and pleasure. Person may become argumentative, sentimental, sad or depressed, face is flushed, and pupils are dilated. Smell of alcohol in breath also found. Stage 2 is a stage of incoordination. In this, blood alcohol level is 100 to 30 milligram per deciliters. In coordination is thought, speech, and action, confusion, impaired memory, slurred speech, staggering gait, impaired skill and movement, blurred vision are also reported. Stage of narcosis. In this, blood alcohol level is 30 to 50 milligram. Patient is in deep sleep, respond only to deep stimuli, excessive salivation, pulse is increased, temperature decreases, and pupil contracted. McEvan's sign, pupil dilated on pinching of muscle of face and neck and again contracted on release of pinch. Stage 4 is a state of medullary paralysis. In this, blood alcohol level is more than 50 milligram. Respiration is slow and status. Skin is cold and clumsy and cyanotics. Pupils are dilated and abolition of reflexes and pulse becomes imperceptible. Now treatment, that was the symptom. Now treatment of alcohol poisoning. What you have to do? Gastric lavage using sodium bicarbonate, safeguard respirations, IV glucose, thiamine and fluids, avoid emetics, ethyl alcohol, 1 milligram per kg in methanol poisoning as 10% solution given IV. 4-methylpyrazole is better antidote for methanol poisoning. Symptomatic treatment can be given. Withdrawal symptom may be treated with carbamazepine. Treatment of ethanol and isopropanol intoxication is largely supportive because of the hemorrhage, gastritis that can follow isopropanol ingestion. H2 blockade or proton pump inhibitors may be helpful. The primary antidotal treatment of methanol or ethylene glycol involves blocking alcohol dehydrogenase. This enzyme can be inhibited by either ethanol or farmipizole. Now, farmipizole should be administered as a loading dose of 15 milligram per kg. Subsequent doses should be at 10 milligram per kg every 12 hours for 4 doses. In addition to blocking alcohol dehydrogenase, significant metabolic acidosis should be treated with sodium bicarbonate infusion if methanol is suspected. Folinic acid should be administered at a dose of 1 milligram per kg with a maximal dose of 50 milligram. It should be repeated every 4 hours. If folinic acid is not immediately available, folic acid can be substituted at the same dose. If ethylene glycol overdose is suspected, the patient should also receive 100 milligram of intravenous thiamine every 6 hours and 50 milligram of pyridoxine every 6 hours. Now, chronic alcohol toxicity, I think we'll do in next class, I think,